Hi, good afternoon everyone, or good evening probably would be better. I hope you are all ready. You're in the right place if you're here for the virtual event. We can see a few people more logging in, so I'll just keep them coming. We've got loads of people signed up for this event, so that's great. A few more coming in. You're in the right place. If you're looking for the Care virtual event, you're in the right place. If you're looking for something different, you are not. Okay, we'll make a start. We've got quite a lot of people coming on now. So welcome along this evening to our virtual information event. So this is our Path to Parenthood virtual event for prospective patients, for you guys to learn everything there is to know about IVF with Care Fertility. So I'm going to start off with a short video just to introduce you to Care really. But first of all, a little bit about the event. So we will go through the IVF treatment pathway as a whole. We're going to talk about diagnosing a fertility problem, the IVF treatment pathway from consultation all the way through to pregnancy support, the techniques that we use in the lab to help you achieve success, the support and the funding that we provide at Care, how you would get started with Care in the first place, and then we're going to do a Q&A session with Dr. Tom Bamford, who is our Manchester Medical Director, which is really exciting. So you can ask questions in the questions tab, or you can ask it in the public chat tab. If you use the public chat tab, people will be able to see your name. So if you'd rather keep it private, you can do it in the questions tab. You can also send any questions that you prefer to ask privately via email to our inquiries team. So you can email at events@carefertility.com. We're going to aim to answer as many questions as we can, but as always, we end up running out of time. There's usually tons and tons of questions. Please don't be afraid to ask them. If we don't get round to your question, then we will reply to your question after the event via email. You can also call our new patient inquiry team. They're with us until 8 o'clock tonight, specifically for this event. So I can see that Jess, one of our lovely team, has put the information there in the chat function. So the number's there and you can give us a ring up until 8 o'clock. So I think that's all of the housekeeping stuff. I'm going to start with a short video just to introduce you to Care.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are Care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualised treatment personal treatment to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with, I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way. And I feel like they lived the journey with us.
So I've had several treatments with Care. I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
I always loved seeing that video. Okay, I'm going to share the presentation now. So the presentation will usually take, hang on one second, let me cross that off and get the right one. It should take around half an hour. It depends how involved I get. So let's just take this back to the start. Wonderful. Okay. So, as many of you may know, we've got clinics all over the UK. So we are the largest fertility provider in the UK. And excitingly, we've just branched out into international waters. So we have clinics in the States and Spain now. So you can see the network of clinics that we've got in the UK, and largely the clinics are spread out so that essentially we can provide treatment to anyone in the country. We think it's really important to have that kind of footprint, because we do believe that family is for everyone, and it shouldn't be about location. You should be able to access the treatment wherever you are in the world now. So it's really easy to get started with Care Fertility. We've got a great team, a great general inquiries team, a great patient support team. We've got a team of people called Care Pals who see you through your journey from start to finish. And as you saw in the video, really hold your hand through the whole journey. So it's really easy. All you've got to do is get in touch in terms of a phone call or an email. And if you have more questions before you want to get started, you can just get in touch with our general inquiry team. And you can see the lovely Shah here on the screen, who's our general inquiry team manager. They'll be able to help you with any query you might have and point you in the right direction for specific treatments if you had any. So the first part of a fertility journey is the diagnosis. Obviously, we want to make sure we're getting the right diagnosis for you so that we can provide the right treatment for you. So we want to take the time to get to know everything about you. You might be a first-time treatment, so you've never had treatment anywhere before, in which case we would want to run a few basic tests to find out if the egg quality was good, if the number of eggs that were available was a good number, if the sperm sample was good. You might be a same-sex couple who want to use donor sperm. So there's lots of different things that we would want to get to know about you and your history and your family planning. If you've had treatment before, we would welcome any previous treatment information or any tests. tests, any results, they're all really, really useful. So we would recommend sharing as much information as possible, and we do this through our online portal. And this is a really good way for us to share information back and forth. So when you're registered with Care, you'll get a secure password to access your specific portal, and in that portal you will find all of the information that's relevant to you. And it's also a place for you to put information about you as well, previous test results and treatments if you've had any. We'll send you a really detailed medical questionnaire onto the portal as well that we'll ask you to complete. It's all digital, and that will just ping right back to us so that we've got all of the information that we need. So we'll review all of that information before your consultation so that the doctor is really aware of your situation and your history. And that will really help us plan your treatment and make your consultation as effective as possible. So here's the lovely George from our Sheffield clinic. In the consultation, our goal really is to listen to what your family plans are and come up with the best treatment options for you. We might not decide at that time what the treatment type will be, but what we'll do is give you plenty of options about the treatment. So we're going to explain relevant treatments for you based on your history, based on your test results. We're going to talk about the chances of success that you have based on your test results and what treatments we can do for you. We're going to give you quite a lot of detailed information. One thing that's really important for us is that you have enough information to make those decisions about what treatment would be best for you. So we're going to give you lots of information, and that will all be digital on your personal portal. We'll give you some information about the support that we offer in the consultation, and also we'll cover the costs as well, so that you go away knowing, if I pick this treatment, this is how much it's going to cost. So that will all factor into it. And then we want to give you time to ask questions as well. Obviously, the consultations are an appointment type, so they do have a time limit. So what's really good is if you have already got questions, bring them with you, write them down, make sure you don't forget them. You'll be given lots of information, so it's important that you've got the time to ask the questions that you want to. So although you might go for a consultation at Sheffield, for example, with George or Tom, who you'll meet later, it really is a network of knowledge and doctors across the group. So whether the fertility issue is something really simple or whether it's particularly complex and you've been through multiple treatment cycles and you've got a very complex history, we've got lots of knowledge around the group to make sure that we do give you the best chance of success. So you've had your consultation. The next thing is to start the process. So during this part of the presentation, I am going to refer to the IVF process as the generic IVF. So we're talking about having eggs and sperm from a female and male and creating embryos in the lab. Obviously, there are tons of different ways that this can come about, but largely this process will be relevant to the majority of you. And as I said earlier, if you've got specific questions, if I don't quite touch on something that you feel is relevant to you, do just pop it in the questions tab or give the team a ring and they'll be able to help. So everyone is different and we do want to do individualized treatment, and that's the point of the consultation, to make sure that we really get down to what treatment will be best for you. It's not a one size fits all. It certainly is something that we value in terms of individualized treatment. So the first step to the IVF process is the ovarian stimulation. We need to get eggs, and we do this using ovarian stimulation through drugs, and these are usually delivered through a needle you can see on the screen here. So you'll be prescribed quite a few different medications, and they're all timed at different points along your cycle. We'll give you a really detailed protocol about when to take those drugs. and which type and what dose. And the dose will all be worked out based on your history and your test results. We will direct you to a video. So here's Diane giving a demonstration of how to do an injection. That video will always be available to you to refer back to during your treatment if you needed any help with administering the injections. So usually you're taking this medication, you can be on medication for quite a while depending on your history and your requirements, but this particular medication where we stimulate the ovaries, you can be on it from between 8 to 12 days. It might be longer, it's not usually less than 8 days, but it may be longer than 12, but that's the average. And what we do during this time when you're on this medication is we monitor how well your ovaries are responding to those medications. So here's Rima from one of our clinics, and what we do is a vaginal ultrasound where we'll measure the follicles growing on each of the ovaries, and that really tells us how well these follicles, which are the fluid-filled sacs that contain the eggs, that really tells us how well they're growing, how well you're responding, and likely how many eggs we're going to get. So we usually do one of these scans throughout this phase of ovarian stimulation. And you can go away from this scan knowing roughly how many eggs we might collect. Sometimes it's more, sometimes it's less. Some of the fluid-filled sacs don't contain an egg at all. And some of the smaller ones contain eggs, but they might be not quite ready for insemination with sperm. We'll come to that a little bit later. But when you are ready, when we feel like your ovaries have responded appropriately, we would do the final trigger injection. And this is the last injection that you would take in terms of the ovarian stimulation, and it would give your eggs a final push to become mature and be ready for egg collection. So then your egg collection would be 36 hours later. It's a relatively straightforward procedure. You can imagine that if you have 4 follicles compared to someone who might have 25 follicles, the procedure can take a little bit longer if you've got more follicles. But basically all we do is pass a needle through the cervix wall to the ovaries, and we drain the fluid from the follicles. So you can see a couple of pictures on the screen here, the black and white ones that look like ultrasounds. The black areas are the fluid-filled sacs, the follicles that should contain the egg. So we drain this fluid from the ovaries, and then the fluid that we collect gets passed into the lab, and the lab team will search for the eggs in the fluid. So it's usually around 30 minutes. As I said, it could take longer, it could take less time depending on how many follicles you've got. When it's finished, you will have a short time to rest afterwards, and then you'll be free to go home and take it easy for the rest of the day. So we've collected the eggs and they're safely in the incubator, ready to receive the sperm. We obviously now need to collect the sperm. So we can get the sperm in a number of different ways. And if you're using donor sperm, it might be frozen. If you're using partner sperm, it might also be frozen for various reasons. But usually, majority of the time, the sample is collected fresh and it's delivered to us on the same day that the female would have the egg collection. So we receive the sperm sample and it goes through a series of washing in the lab to remove all of the debris that might be inside the sample, so that we're left with the good moving, good looking sperm ready to inseminate the eggs. So I think I had a short video there to show you the way that we might assess the sperm. Yes, let me show you this quickly. So you can see here the sperm moving on the screen, and what we use is an instrument called a computer-aided semen analysis. And what this does, it tracks the sperm's movement. So you can see the blue lines where the sperm are moving, and it tells us essentially in seconds how many sperm there are in the sample, how well they're moving and what they look like. So this sample, we can see we've got 24 million sperm, and 85% of them are moving in the right direction, and 12% of them look normal. So hopefully you managed to see that video. Let me load the presentation back up. So we've gone through the process of collecting the eggs and collecting the sperm. They're both ready for creating the embryos. So what we do is attempt fertilization on the eggs. So we would ordinarily, if the sperm sample is what we would class as normal, so there's enough moving and they're moving in the right direction and they look normal, or a good proportion of them look normal, then we'll go through the basic process of IVF. And that's where we would put around 200,000 sperm in the dish with the eggs and just leave them overnight and let them do what they're supposed to do. Sometimes if the sperm sample is a little bit poorer in quality, so the number of sperm that we have, or the way that they're moving, or the way that they look is a little bit lower than what we would like, we would do something called intracytoplasmic sperm injection. And that's the little image that you can see here in the top right hand side. That's a kind of a stock image that you see when people describe IVF. This is actually the process of ICSI. And this is where we would, the embryologists in the lab, you can see one of them doing it here on the screen, will manually select a sperm from a sperm sample using a very high powered microscope to make sure that the sperm is normal and it's moving in the right direction. And we'll manually inject that sperm into each one of the eggs that's been collected. So this is where the sperm might need a little bit more of a helping hand to fertilize the eggs. The fertilization rate between the two processes is very similar. Some people think that because we're manually injecting the sperm directly into the egg, the fertilization rate would be higher, but it's not, it's around the same. So we would hope for around 70 to 75% of eggs would fertilize. So if you had 10 eggs collected, we'd hope that maybe 7 or 8 of them would fertilize. Sometimes it's more and sometimes it's less. It just depends on the circumstance. So I do have a quick video to show you ICSI because it's very interesting. Hopefully you can see it. So you can see the egg is taking up most of the screen here, and then there's a little needle on the side that's got the sperm in. We push that needle into the egg. We just suck up a little bit of the egg to break the membrane so that we make sure that the sperm definitely goes in. And then we just slowly deposit the sperm into the center of the egg and remove the needle. So we would do that for every egg that we would class as mature. Not every egg that you have collected will be mature to go through ICSI, but we would hope for around 80 to 90% of them would be. So if you have 10 eggs collected, hopefully 8 or 9 would be injected, and then of those, maybe 6 or 7 would fertilize. So the really interesting bit for us as embryologists is the embryo development. We're very lucky to have technology in our labs, which is the time-lapse technology. And this monitors the embryos 24/7. So it takes an image of every single embryo every 10 minutes for the entire time that it's in the lab. And this gives us essentially a video of the embryo development. And it helps us select the best embryo, but also give you a lot more information about your embryos and how they've been developing. So this is Alex, one of our lab managers from London, and the images in the top right hand corner, you can see there's 4 images. The top left hand side is it looks like an egg. It's just one cell. It hasn't developed at all. The next image, the embryo has 2 cells, and this is what it would look like around day 2, so 2 days after they've been collected. The image on the bottom left is around day 3. It's got around 6 cells. And then the image on the bottom right is a blastocyst. And this is what we would hope the embryo would become by day 5 or day 6 after egg collection. So we will keep in touch with you throughout this time. The embryos are with us for 5 or 6 days after they've been collected, and we'll give you a call the day after the egg collection to let you know how many have fertilized. And then we'll give you a call on day 3 to tell you how they're doing, give you a bit of an update in terms of quality. And then we'll give you a call on day 5 as well. And day 5 is usually the day that you would have an embryo transfer, if that was the treatment plan that we were going with. We've got a lot of technology in our labs. Again, we're very lucky to have that. And we've just won the National Technology Awards for our artificial intelligence care maps technology. So we've got lots and lots of data because we're a large group. We have been able to utilize artificial intelligence to help us decide which embryo is the best out of a cohort. And this artificial intelligence really helps the lab teams to make informed decisions and also to give you information and manage your expectations. So what we can do with care maps, if you choose care maps as a treatment option, is when the embryo has reached a blastocyst stage, the embryo is given a score. It's assigned a score by the system from score 1 to 10. And 1 has got the lowest chance of creating a live birth, creating a baby, and 10 has got the highest. And what we can do is tell you what score the embryo has reached and what percentage chance of a baby that means. And that information is really useful for you to manage your expectations in terms of your chances of success. The other technology that we're very familiar with is pre-implantation genetic testing. So the image on the right-hand side here is an image of us taking a biopsy of a blastocyst. And this is a technology that informs us of the chromosomal normality of the embryos in culture. When we do this procedure, we remove 5 to 10 cells from a blastocyst, which would have hundreds and hundreds of cells by this point. And we'll send that small sample of cells to our genetics lab for testing. The blastocyst itself would be frozen and it would stay frozen until we had the results from the genetics lab. And that would tell us if the embryo was chromosomally normal or chromosomally abnormal. If it's chromosomally abnormal, we wouldn't transfer that embryo. The chance of it creating a pregnancy is basically 0. If the embryo is classed as normal, then we can give you again, a percentage chance that that embryo will create a pregnancy and a baby. And they are the embryos that have got the highest potential among all embryos. If the embryo is chromosomally normal, we know it's got the highest potential. So all of our clinics have got access to these technologies, and there's other technologies as well that are available that I'm not going to go into too much detail, but would be discussed with you if your consultant thought that they were relevant for you. So things like the sperm oxidative stress test and the Care Unity test, and we also do lots of cryopreservation for fertility preservation patients as well. All of our clinics achieve fantastic success rates across the board, and you can find all of the individual success rates on our website, or you can ask in the questions tab or send us an email if you want some more specific information. So I've got a video to show you of care maps. I should have opened with that because it's very interesting. So you'll see here, this is a video of an embryo developing. So it's about day 3 now, and each cell you can see is dividing, and then it kind of goes together into a ball of cells, and they communicate with one another and decide where they're going to go. And then it starts to form the blastocyst, where the cells start pushing out to the outside, and we have a mass of cells forming at around 3 o'clock. So you can see that it's starting to hatch out of the shell, sorry. And then you can see the inner cell mass was just at about 3 o'clock. That inner cell mass part is the bit that becomes the baby. And that's the bit that we look for in the lab. When we're grading the embryos, we want to see that specific cell type. And that really gives us information about how well the blastocyst has developed. So depending on what treatment you have, whether you decide to have care maps or PGTA or any of the other technologies that we offer, eventually you will hopefully get to the embryo transfer stage. We in the lab will identify the embryo with the highest chance of potential, and we'll talk to you beforehand and let you know how the embryos are done and if you've got any embryos for freezing. It's all done under ultrasound guidance, and it's a very straightforward procedure. So you can see it being performed here. They've got an ultrasound probe on the abdomen, and that just tells us that we're going into the right area with the catheter. And it's performed by either consultants or our advanced nurse practitioners. And there's no sedation, it's walk in, walk out, and should be relatively straightforward. You can go about your normal activities afterwards. So then after the embryo transfer, there's the dreaded 2-week wait. And this is a really difficult time and feels, I'm sure feels like a lifetime to many. But after the embryo transfer, we'll give you information about what you need to do, what you need to avoid doing, what you can and can't do. And we'll give you a date for you to perform your pregnancy test. And we'll also give you some medication to help support your womb lining to make it as hospitable for the embryo as possible. So you would do your pregnancy test kind of anywhere between 11 and 14 days after the embryo transfer. It does depend on when you've had the embryo transfer performed. And then we would book you in for a scan appointment to check if there was a heartbeat after the embryo transfer or not. All being well, there is a heartbeat, and that's where we want to get to, and that's amazing. We would discharge you to your GP, and you'd move into the normal antenatal care with your GP. If it's a negative result, we'll offer you loads of support. We're always on the other end of the phone. Give us a ring, and we can talk to you about next steps, and book you in for counselling as well if you needed to. So that's the treatment journey in a nutshell, from kind of consultation all the way through to pregnancy test, pregnancy scan. And I just wanted to now touch on a few kind of peripheral services that Care Fertility offer. We do offer the whole breadth of treatment services, and as I said, that the process that I've just gone through is very generic, and there might be specific treatment options that you need based on your circumstances. So we have a huge donation service at Care, both donor eggs and donor sperm, and we've got our own bank of both. So we have a large sperm bank, donor sperm bank from UK donors, and we also have a large egg bank from UK egg donors. So the eggs and sperm are all frozen, and if you do need to use donor eggs or donor sperm, you'll be given access to kind of a digital bank, if you will, where you can select your donor based on their characteristics. So we've got over 25 years of experience in donation, tons and tons of people on the team for the donation, and we'll support you all the way through. It is quite complex, so we do offer specialist counselling, and we do have specialist administrators and nurses that do deal solely with patients going through treatment using donation. So yeah, we also, although we do have donors from the UK, which is what we try and we aim for, we often also get sperm from overseas donor banks. So there's a list here that is they're just our donor sperm banks that we partner with, and they're in many different countries, Denmark, over in the States, Sweden, and we also do partner with some UK donor banks as well. This is mainly because you might come across patients who need specific characteristics, and that we don't have those characteristics in our donor bank. We can then give you access to, we can then put you in touch with these other donor banks, and they might have donors that fit the criteria that you're looking for, the characteristics that you're looking for. We are very proud that we've also this year won the award for the Surrogacy Clinic of the Year from the National Surrogacy Awards. This is an amazing accolade, and really is a testament to our surrogacy team, who just put their hearts and souls into making sure the patients have the best journey they possibly can. Surrogacy is very complex, but we, as I said, we're with you every step of the way, and you couldn't be in better hands with our great team, our great surrogacy team. We offer lots of support with Care as well. We recognise that fertility is a tough journey, lots of ups and downs, and we want you to have access to the care and the support that you need at all times. So we do offer counselling. We've got a 24/7 online forum that you can talk to other patients with, and we're always on the other end of the phone as well. You can find more information about the support that we offer online, but we've got some great schemes like the buddies, and we've got some male fertility clinics as well. So lots and lots of support at every turn, and a great group of counsellors as well who are very specialised in fertility treatments. And then just a last bit about the funding options that we have. Again, we recognise that fertility treatment can be expensive, and we want to make sure that it's accessible to as many people as possible. So we do have a programme called Care Pay, and this is an exclusive IVF funding programme, which hopefully makes your funding of treatment easier. And essentially, we have different products within this Care Pay programme, and we can talk to you about all of the possible options if they're relevant for you. So we do a multi-cycle programme where you have multiple cycles, and the goal is to have a live birth. If you don't have a baby, then there's obviously refund associated, and then we do the same with donor egg treatments as well. So we've got a specific team that deal with this, our Care Pay team, and the number's on the screen there, and you can get in touch with us and ask some more questions about that. So within the Care Pay packages, we include everything: cycle monitoring, egg collection, the embryology procedures, transfer, the freezing of any remaining embryos and the subsequent storage, and culture up to the blastocyst stage, and care maps as well is included as an extra. The only thing that's not included in that is the medication, but that's pretty standard. Okay, so this is a new slide that you get a consultation discount. That's great. So if you ring our new patient inquiry team on that number and quote the virtual event August, you get a £150 consultation discount, which is really, really good. So now we're on to our Q&A, I believe. So hopefully Dr. Tom Bamford will be joining us soon. We've got a lovely team behind the scenes working their technological magic to get him online. I'm hoping he's going to show. Let me see if there's any. We've got lots and lots of questions. If anyone has got any questions, now's the time. Pop them in the chat and we'll get to them. I can't see Tom though. Okay, so I think I'll make a start whilst we wait for Tom to join. We've had 49 questions so far. So the first question that I've got on here, I have eggs frozen with Care, but my husband's semen analysis showed only 1% normal morphology. Is it still possible? Oh, here he is. Hello.
Can you hear me?
I can hear you, but you've frozen a little bit. Oh, you're back.
I'm back? Okay, yes. Good. Sorry, it wouldn't let me join. So
that's all right. That's welcome to the Q&A.
Thank you very much.
So I started with a question. Let me carry on, and you might be able to help as well. So I've eggs frozen with Care, but my husband's semen analysis showed only 1% normal morphology. Is it still possible? I don't want to waste my eggs by thawing them. How many eggs do they usually thaw at one time? I froze 30, but guessing they wouldn't advise thawing them all at once.
Wow. Well, yeah, first of all, most patients wouldn't get to 30 eggs, so that's amazing that you've got that in the first place.
Yeah.
In general, we would recommend, if you're definitely wanting to have treatment with your partner and create a family with that partner forever, we would recommend thawing all of the eggs at once, because it's the most cost-effective thing to do for you for a start. In terms of the morphology is probably out of all of the parameters that we really look at, is the least important thing. So I would reassure you a lot on that actually it's very, very variable from sample to sample.
Yeah.
There are things that a man can do to try and improve the appearance of their sperm. So the life cycle of a sperm is about 12 weeks-ish. So really what happens in those 12 weeks leading up until the sample is really important. So whatever they can do to improve their lifestyle and their diet, that will really affect the quality of the sperm, particularly the morphology. So a simple fertility supplement for men is often quite useful. We can often buy them over the counter. They don't need to be very expensive. And that can often help. And having a Mediterranean style diet, that's often what's quoted for good sperm. So all of those things can be incorporated, but in terms of the actual morphology, I wouldn't worry too much anyway.
Yeah.
And with frozen eggs, we typically recommend the sperm injection as part of the procedure anyway, so you wouldn't really need anything extra.
Yeah. So although 1% sounds really low in terms of the general population, what we class as normal is only 4% normal.
Yeah, exactly.
So it's really 1% is actually quite a lot. Yeah. Sperm production is like a factory. It's all quantity, loads and loads and loads of it mostly. But then largely they're not great looking. So yeah, we would do ICSI anyway, and the embryologist would find the best looking sperm, and they would inject the eggs. So there's nothing to worry about with that. So next question, Tom. I'm at the start of my fertility journey. I've PCOS and don't regularly ovulate, so I need to try letrozole or Clomid. This session has only been about IVF, which I'm guessing is the last option. Are you able to talk through the time frame and process for ovulation meds, please?
Yeah, so first of all, we'd want to establish that you're definitely not ovulating. So we do some blood test for that, or you can do some urine testing yourself at home to check for ovulation. And then if that's showing that you definitely aren't, then we can start you on letrozole or Clomid. Typically these days we use letrozole more often than Clomid because it's a little bit safer. The main risk with the process is twin pregnancies. So they happen in about 10% of ovulation induction cycles. So with this, it's a relatively simple treatment compared to IVF. You start a tablet that you take between days 2 and 6 of your cycle. And then you then typically come for some monitoring, so scans and bloods from around days 10 to 12, depending on the clinic of your cycle. And then what we want to see on those scans is that you're developing a follicle where you're going to release an egg in the middle of your cycle. And we check that process has happened through the blood tests. And then we would advise you when the best time is to have intercourse. So the doctor will advise you whether that is the best route for you to go down, because it's often dependent on other factors such as your age as well. It might be that we would say to you that IVF might actually be the best option, even though you have an ovulation problem.
Yeah. And then probably a little bit associated with that, or maybe not, but could you provide overview and some information on IUI? Because we didn't touch on IUI in the presentation.
Yeah, so IUI can be similar in that you can use the same drugs, and then at the time that we would advise the timed intercourse, that's the time that we would do the IUI procedure, roughly, depending on the situation. The IUI procedure itself is again relatively straightforward. So it involves no sedation for most patients. We would do a speculum examination like a smear test, and we thread a small catheter like a tube through the neck of the womb into the uterus, and then we inject either partner or donor sperm into the uterus. Most patients that have this procedure don't need any medication in order to go through the cycle, because they're ovulating already on their own. There are a group of patients that we would give medication to improve their chances.
What kind of patient group would you advise IUI for rather than IVF?
Yeah, that's a good question. So IUI, by and large, in our clinics, IUI is typically done by same-sex female couples. That's probably the main treatment cohort, or patients that just don't want to have IVF and they want to try something else, because often patients might feel that that's quite a big jump. The key thing to realize really is, if you are ovulating and you're having regular intercourse, if you're a heterosexual couple with your partner, then actually IUI typically doesn't offer a huge amount of benefit over regular intercourse. But your doctor would talk to you really about that, about your particular situation, your semen analysis, and so on. It's all in the context of your results.
Yeah, because I think that's the thing about IUI, is it does feel like a jump from IUI to IVF, like procedurally, but also financially. It feels quite a big jump.
Yeah, it does, and it's not everyone is ready for that straight away. So yeah, your doctor would talk about what you'd want to do, and the key thing I think about IUI is that you have to appreciate that per cycle compared to IVF, the success rates are lower. And that's why we have packages that are in groups of 3s. So for most patients, for example, that are younger than 35, the success rate for a live birth is about 12% to 15%. So if you think you need really 3 months of treatment at least to give yourself a realistic chance of having a baby.
Yeah. Okay. So you talked a bit about improving sperm quality, and that sounds really easy, just changing your lifestyle and things like that. Do you recommend anything to improve egg quality? We've got someone using CoQ10.
Yeah, lots of patients will come to us on a whole pharmacy of different supplements, and some patients won't be on anything. The evidence for a lot of these supplements is actually quite poor. Now, the main things that we would advise for any female prior to fertility treatment is folic acid, and that's to prevent neural tube defects in any baby that's born. It doesn't really do anything for your chances of conceiving. It just improves your pregnancy outcome at the end. The other thing is vitamin D. Now, that is associated with lots and lots of good pregnancy outcomes, so we would also recommend that, and often it's things like Pregnant Care or other fertility supplements. Coenzyme Q10 is definitely something that I think we will see more and more commonly. Lots and lots of patients take it. It essentially acts as an antioxidant. So these are chemicals that can affect the quality of eggs and sperm, but in this situation we would be talking about eggs. So coenzyme Q10 mops up all of those chemicals and therefore potentially improves the egg quality. If you look at the best studies on coenzyme Q10, at the moment it's not clear as to whether it definitely improves your outcome. But most fertility doctors, I think, would say that in a few years we probably will have enough studies to support its use. So
and you can get it over the counter, can you?
Yeah, you don't need it prescribed.
Yeah. Okay. I'm keen next time to opt for ICSI in case that does help with success. Is that something I can state as a preference, or would your team want to assess the sperm sample on the day and offer IVF only?
Yeah, it's a good question. So it really depends on your situation and the semen analysis. If the semen analysis, I presume, has been normal and that's why you've had IVF before, I think that we would look at the whole of the situation. So what was the fertilization rate like? What was the blastocyst development like? And then make a decision from that. Using ICSI just on its own doesn't improve your chances of having a baby if the semen analyses are normal. We would advise you based on your history, really.
Yeah, and there's lots of other things that we can recommend before we recommend ICSI, if the sample is normal and good enough for IVF, there are other things that we've got in our arsenal really to help you, rather than doing ICSI, because there are risks associated with ICSI as well, and we don't want to do it if we don't have to, essentially. How many ultrasound scans are needed during ovarian stimulation?
It depends typically on the clinic and how, or the type of treatment that you're having, or the type of stimulation that you're having. Most clinics would do about 1 or 2. Some clinics will do, or not a part of our group really, will do lots and lots of scans, and actually there isn't very much evidence to support that, because what we know is that there isn't very much that you can change within a cycle once it's started to improve the outcome. So actually doing lots and lots of scans might just create more anxiety, and really you're better waiting till nearer the end, once we can do a proper assessment of what the follicles look like. About 1 or 2.
And that's why it's important for us to get the diagnosis right from the start and the treatment plan right from the start, so that you start off on the right foot, and then we don't have to correct anything or change anything throughout.
Exactly.
What's the average number of attempts needed for IVF? Are there any risks the more times you try?
Largely success rates in IVF are dictated by female age. So it really depends on how old you are, and what would happen at a consultation is that we would look at the whole picture. So we would look at your ovarian reserve, and what we mean by that is your egg store. So typically we would assess that through an AMH, which is a blood test, and that's a hormone released from the follicles that gives us a good idea of how you'd respond to stimulation. And the other way that we would assess is through an ultrasound scan, by counting the follicles that are there in that cycle. So we would use that information and your age to give you a good indication of what we think success would look like. And success might look like 1 cycle, but it might also look like probably we'd need multiple cycles. And that's when the doctor would start to talk to you either about packages or types of treatments that we have called banking, for example. And these are approaches where we try and store up the embryos as quickly as possible, in order to try and get 1 normal embryo, which Amy was talking about before, is the best endpoint for putting that embryo back into in terms of achieving a baby.
And what about risks for the more times you try?
And there's lots and lots of studies been done on risks involved in IVF, things like breast cancer, womb cancer, and there is no indication that there isn't a significant link between the two. So that's reassuring data in itself. The other thing really is sometimes patients will worry about an earlier menopause, which makes sense. If we're stimulating more eggs in the cycle to be released, is that going to mean that's going to shorten the time to your menopause? And there is some data to support that, but typically those patients will have had lots and lots of cycles of IVF. So having 1 or 2 cycles of IVF isn't going to do anything drastic to the age of your menopause.
Okay, we've got a couple of lengthy ones here. So I'm currently under the NHS fertility clinic, but have not yet got a diagnosis for the possible cause of my, in brackets, female infertility. Please could you explain if/how any consultation or treatment with you, excluding IVF, would affect NHS funded IVF as an option in the future?
Wow, very good question.
That's a great question.
Well, first of all, I just wanted to mention, you don't always get a diagnosis for a fertility problem. So we can't necessarily promise that, because about 30% of couples, unfortunately, we won't be able to give you an answer. And there will be a problem or something that's delaying the chance of you conceiving, but it's nothing that we can identify from tests, or anyone for that matter. In terms of the NHS funding, it really does work upon your postcode, and it's frustrating that that's how it works, but unfortunately that is how the UK functions for IVF funding. So the rules on that will be very, very different even within my clinic in Manchester, some areas of Greater Manchester, the private cycles of IVF will affect your NHS funding, and some of them won't. So I would just get the advice of your local authority on that.
Yeah, and they can get that information through the internet. They could Google. They're called ICBs now.
Probably the best thing to do is, if you're thinking of having a consultation at one of our clinics, is to just get in touch with us, and then we can get in touch with the local team at that clinic, and they will have a better idea than I will about, for example, Leeds or something.
Yeah. Okay. Do you need to time embryo implantation? And are there ways to increase the chances of successful implantation? And how much time off work would you need between embryo formation and implantation?
Yeah, so we time the embryo implantation in a fresh cycle depending on the age of the embryo, which is typically 5 days. And then therefore you put the embryo 5 days after the egg collection back inside the uterus. In a frozen cycle, what we do is we time that depending on the type of treatment that you're having. So a lot of our patients will be on medicated cycles. So in those cycles, we give you estrogen, we check the lining, and then we start the progesterone. And again, once you've started the progesterone pessaries, 5 days later, you have the embryo transfer. And that's just to do with creating a window of implantation for that embryo with a hormone. There are ways that we can check that we're definitely putting the embryo back at the right time, and that's called an ERA test. And not everyone needs this test, but it's sometimes something that we would recommend. In terms of the other questions, what was the other questions, Amy?
Are there ways to increase the chances of successful implantation? Which is, I mean, how long have we got?
Yeah,
It's gone on forever.
Exactly.
But generally, it's what I was talking about in the presentation, right? The maximising success. So care maps, PGTA, all of those kind of.
It's lifestyle, and then if you've been in the unfortunate position that you've had implantation failure a number of times, that's when we, as doctors, would start to talk to you about extra tests that we might recommend. One of them I've mentioned. Some of them might be blood tests and so on. So there are things that we can do to investigate why that might be happening. Most of the message really is reassurance, because we know that usually it's to do with the embryo that we're putting back and the quality of the embryo, rather than anything to do with the patient. And that's why it's really important at the start to make sure that we're putting the right embryos back.
Yeah. And then how much time do you need off between embryo formation and implantation? Well, we just usually say you don't need to do anything special. Maybe treat yourself as if you're pregnant. Don't do anything crazy heavy lifting or anything like that. But you can go to work as normal and go about your daily lives. If it was a natural conception, you wouldn't know that you were pregnant at this point. So it's just treat yourself as if you are, but you don't need to go out of your way to go.
There have been studies where they've made patients have bed rest, haven't they, after we put the embryo back, and actually the patients that were on bed rest did worse, which is
associated with, or they've maybe assumed it's associated with kind of circulation and the blood flow to your uterus, and making sure that that's all, it's getting the blood flow that it needs. So being active as well is good.
And presumably lying there thinking about your embryo weight couldn't be any worse. So
yeah, exactly. Okay, last couple of questions, because we've been going for a little while now, so we'll do some last quick ones. I have PCOS and my partner had a vasectomy 10 years ago. Are we best starting with a reversal or going straight to treatment?
So with that one, it depends on the type of treatment that you're going to have. So presumably the best thing to do in that situation, if you're going to try and have ovulation induction, so that's the Clomid or letrozole treatment to make sure that you're ovulating. So that might also not be the case. So just because you have polycystic ovarian syndrome doesn't mean that you've necessarily got an ovulation problem. So I think the first thing really is just to have a consultation, because that is a little bit more complex. Probably needs teasing out on a one-to-one basis. But if you are thinking of IVF, then for example, it might be that an SSR is the most straightforward way to do it in terms of the risks to your partner.
Yeah, so that's where we would surgically retrieve the sperm from the testicles rather than relying on sperm through ejaculation, basically.
Exactly, yeah.
Yeah. How is OHSS dealt with if it occurs during the cycle?
So it depends on how severe it is. So we've got a way of scoring OHSS into 3 different categories. And we typically, the only treatment that's needed is monitoring. So we really just keep a close eye on you. We might do some blood tests. The key thing with OHSS, and for those that don't know, this is when the ovaries have over-responded to the drugs that we give in an IVF cycle. It's probably the main risk that we try and avoid in IVF. And luckily these days, we've got lots of very clever drugs that are better at avoiding it and ways of managing your treatment to avoid it in the first place. But sometimes in a very small number of patients, it's unavoidable. So we would monitor it with scans and blood tests. And the condition in itself does make you more likely to develop a blood clot. So typically we'd put you on blood thinners as well. And if this is something that you develop, it's something that we consider is all part of your treatment. So we just look after you through that process.
Yeah, and if you do develop OHSS, then we wouldn't be recommending a fresh embryo transfer, because having an embryo in your body whilst your body is also hyperstimulated exacerbates the hyperstimulation and you can become more poorly. So we would always recommend freezing embryos, getting you better, and then transferring the embryos on a frozen cycle. But we're very good at recognizing the signs of OHSS, and you will also become very good at recognizing the signs of OHSS because we give you tons of information about it. So you know to get in touch if you start experiencing any of the symptoms.
Yeah, and typically your doctor will highlight it for consultation if they think that you're someone who might be at more risk of this, because it is a select group of patients. It's not most people.
Yeah. Okay, last one. I feel like I want to say this because it's I want to give them hope. So they've had 3 rounds of treatment. They're mid-treatment now.
Okay.
So round 1, 11 eggs, 7 mature, 4 tested, 2 normal, both miscarried. Second round, 3 eggs, 2 mature, 1 fertilized, 1 abnormal, no transfer. Third round, 6 eggs, 4 mature, 3 fertilized. They've been tested and they're getting the results tomorrow. Do I have hope? Not sure if I need egg or sperm donation. So, I mean, from my perspective, that is a really good way of seeing how cycles differ within a patient. So first round 11, second round 3, third round 6. It's just, they are so variable, but the maturity rate that you get is good. The fertilization rate that you get is good. It's just the embryo, the numbers, isn't it? It's just the numbers that you get at the end of it. So I always think, it depends on your age because we don't have your age there, but I always think if you're getting eggs and you're getting fertilization and you're getting embryos developed, I would say it's difficult to move on to donation. There's other things that you can do before you move to that point. So I don't know if you want to add anything, Tom, about that.
Yeah, it's a difficult transition for a lot of couples to make it from using your own eggs to donor eggs, and that's something that we would give you a lot of support on. And it's not a decision that we would necessarily take lightly either. But for some couples, of course, it is the right thing to do. And we do a huge amount of donation cycles at Care. And obviously lots and lots of couples are really happy with the outcome because they've got a child that they love at the end of it. But that is a process that's very difficult to come to terms with. So we would just guide you. Really, it sounds from me, and I'm agreeing with Amy, is that it doesn't sound like you're there at this stage yet, but it's very difficult without knowing the whole and the quality of those embryos and so on.
Absolutely,
So that would all be taken into account when counselling you about both options. And really, we would help you. We're not going to force you down one way or another. We just present the facts really, and your chances with one route versus another. We would help and support you make the decision that's right for you.
Yeah, absolutely. But don't give up hope.
No.
Carry on going. You can do it.
Yeah.
Okay, that's it. Thanks, Tom. You've been a delight.
Thank you very much.
I'll see you soon.
See you soon.
Bye. Okay, so we're going to end on a couple of videos, just a bit more information about care. So we'll start with the first one, and then after this I'll say my goodbyes and leave you with a closing video as well. Oh, hang on a minute. This is a video of PGTA. It's interesting nonetheless, for you to see how we do biopsy. So I will leave it playing. That's the small number of cells that we would take away from the embryo just in that tube there on the right, and that's us removing the cells from the embryo as easily as we can. And then you'll see the cells pop out, and that's what we send off to be tested. So it's an amazing technology, PGT. So let me see if I can click the right video this time. Here we go.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what Care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, And that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
Okay, thank you everyone so much for joining the virtual event. I hope you found it useful and informative. If you had any questions that haven't been answered, feel free to get in touch, give us a ring, send us an email. We've got the team with us until 8 o'clock tonight. So, I mean, that's only 18 minutes, but they're still available for the next 18 minutes. Give them a call, and I'll leave you with a few final words about care.
1 in 6 people need help to grow their family. You're not alone. And our Care family will do everything we can to help your dream of family come true. There are over 50,000 care babies in the world today. And behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.